Thank you. I'm Dr. Agonafir Takali, the country director for Malaria Consortium and the president of Ethiopian Public Health Association and the general secretary of Africa Federation of Public Health Association. Today, my role is as a master of ceremony. Ladies and gentlemen, I feel privileged and honored as well as humbled to facilitate this timely webinar on decolonizing public health, Africa, and the tropics. This webinar is one of the 2025 plans of Africa Federation of Public Health Association Executive Committee. There are a lot of milestones up until now achieved by the African Federation of Public Health. And Professor Asuzu, Michael Asuzu is the president of African Federation of Public Health Association. He will chair the sessions. And Dr. Alamayo, who is the executive director of Ethiopian Public Health Association, where Africa Federation of Public Health Association is hosted, will be a timekeeper, and he will notify the chairperson using his talent. And I will try to introduce very shortly their massive CVs of our three honored and respected speakers. I will start with Professor Kofi Busa. He is the former director of healthcare services at the West Africa Health Organization, WAHO. He previously taught on the world's first innovatory BSCO herbal medicine degree program in Midlands University in the UK. He currently holds multiple academic roles, including adjunct associate professor at UNIMED, Ondo, Nigeria, associate professor and director of postgraduate studies and research at Pentecost University in Accra, Ghana, part-time lecturer in the Department of Chemistry at the University of Ghana and the Natural Product Chemistry and the School of Health, Sport and Biosciences, University of East London, UK, principal postgraduate supervisor at the Faculty of Medicine, Lincoln University in Malaysia, and he has immense experiences also in Nigeria, in ECOWAS. And I'll go directly to the second speaker, Professor Adubuyako Nola Adilfe Ostilu. Maybe I might have mispronounced your name. I'm sorry, Professor. She is highly experienced ophthalmologist in the University of Lagos and teaching hospital in Nigeria. She's a former chairwoman of Lagos State Traditional Medicine Board and Africa Traditional Medicine Practitioner. I have tried to save time in shortening her CV. Finally, I'll go to Dr. Tarfa Simon Kene. I feel that I'm introducing an Ethiopian because his name is related closely to Ethiopian. Is an experienced public health physician, epidemiologist, and medical statistician and health system development expert who has managed several public health research field activities and projects. He is the chief executive officer of Ave Health Sense Limited, a public health social enterprise organization based in Abuja, Nigeria. He is the current president of Association of Public Health Physicians of Nigeria. He has previously worked with several local and international development partners like the US Centers for Disease Control and Prevention, which is still live in USA. He is multi-talented with diverse knowledge and experience and has co-created the Access Bank Solar for Health product to finance hospital and other health facilities solar installations. He is the project manager of the Race for Healthcare project focused on providing solar solutions for hospitals and other health facilities in Nigeria. I will now kindly and respectfully invite Professor Michael Asuzu to lay introductory remark and chair the sessions. And it is planned that each presenter will have 25 minutes presentation, 40 minutes discussion finally, and Dr. Alamayo will give sign to keep the time. Thank you, Professor Asuzu. Back to you.
Thank you, sir. Well spoken. Ladies and gentlemen, I'm happy that we're here. Many things are happening in the world and in Africa. And this is just one of the webinars we're going to run this year. We are privileged to have very experienced people who are going to show us only two of the many ways we can decolonize public health in Africa. The colonizers have done quite a lot of good to us, and we must be grateful to them. But because they came from their own perspective, there are many things about us that they didn't reckon with and didn't develop very well. To be certain, when I was a kid, traditional medicine had a regulation board, the Ministry of Health. And in my village, all the herbalists who wanted to be licensed had license. They pasted their license on wooden boards on the trees in front of the road leading to their house. So you know where they were. But they didn't advance that much. And when we took over, we haven't advanced it much. So the blame is on us more than them, I would think. So if we wake up now, that would be good. When I qualified in medicine, my father's cousin, first cousin, who inherited herbalism in our family, because in our family line, called me and said, this should actually be in your father's line because your grandfather is the first son of our grandfather who is a herbalist, and he should inherit it. But he didn't. I'm the only son of the last son. I inherited it. If you learn the white man's own and don't learn our own, when we meet our ancestors, when we all die, you will account for it. That's how serious this matter is with me, and I hope it will be with all of us. So without much ado, if any of the three speakers can lessen the time, because we didn't start in time, and we had planned for them to take 25 minutes each, so we can have 40 minutes to talk. We'll open the floor and let Professor Busia please talk.
Okay, good afternoon to everyone joining us from around the world. And thanks to the NC for the introduction. Just to put things into context, I'm actually the Pro-Vice Chancellor of the Pentecost University in Accra, and also Editor-in-Chief of the Journal of Herbal Medicine. My topic is actually on promoting African traditional medicine to decolonize public health in Africa. And I must say that I will preempt my presentation with the fact that before there were stethoscopes, there were stories. Before there were pharmacies, there were forests. Long before clinical trials, African herbal medicine nourished bodies, balanced spirits, and sustained communities. Today, as global health races ahead with AI and biotechnology, we must ask what ancient remedies we dismissed. What healing wisdom lies in the roots we have forgotten. So today, we are not just exploring traditional medicine, we are reimagining the future of public health through Africa's own knowledge systems. Now, surely health equity demands more than just technology. It calls for relevance. There must be trust and access. And African traditional medicine offers promising culturally grounded solutions, which when harnessed can transform care for underserved communities in particular and drive a truly inclusive, resilient, and decolonized public health future. So in actual fact, health is not just a privilege for a few, or for a right for all. To heal our communities, we must embrace every form of knowledge that has kept them alive. The rich heritage of pre-colonial African healthcare meant It meant harmony between body, spirit, and environment, and is still the case today. This is rooted in communal life. The practitioners of the day pass their knowledge through oral traditions and apprenticeships. Now, treatments were based primarily on biodiversity, and there's tons of that in our region. And of course, ecological wisdom. They really knew their art. Now, African healing systems evolved through observation. So we had empires or local people such as the Akan people of Ghana, the Yorubas, the Igbos of Nigeria, the Zulus of South Africa, Fulani, Berbers, Nubians, and many more. These people developed complex medical wisdom. They had such complex medical wisdom, which was preserved through proverbs, through myths and rituals. Now, despite colonial suppression, these traditions remain vital to culturally rooted decolonized healthcare today. And many people still subscribe to that, as I will show. Traditional medicines, what has been its global impact? What comes into mind immediately is the drug artemisinin, which has been used, derivatized into other forms of anti-malaria. This was derived from a Chinese medicine, and it changed the treatment of malaria. And as an icing on the cake, it won the discoverer the Nobel Prize in 2015 for medicine. We also know of quinine, which was inspired by indigenous South American use. It was something that was used routinely in South America and led to the first anti-malaria drugs. Africa has also got a few things, Prunus africana for prostate health, Southerlandia fruticens for immune health. And of course, our countries also have quite a repertoire of medicinal plants, which time will not permit me to go into. There also abound expert care in bone setting, midwifery, and wound healing. Now, this is Professor Yu Tu from China. It turns out that to discover artemisinin, she had to dig deep into Chinese medical texts from several dynasties. And when she uncovered the compound called artemisinin, it's reported that she tested this, she volunteered herself to be the first human subject. And as I said, this one had the Nobel Prize in 2015 for medicine. So it tells you the potential of herbal medicine, for that matter, or traditional medicine, it can do if it handles properly. Now, Africa's public health has a lot of challenges, and at the same time, means opportunities. We know of the high disease burden of our continent, in particular, infectious diseases, malaria, TB, HIV, hypertension, diabetes. Now, chronic diseases are on the increase. And many people still rely on traditional remedies as a primary source of healthcare. Indigenous knowledge dismissed as superstitious and pagan, so little research was given to it or funding for African remedies. A number of the research that goes on are laboratory-based, not clinical trials. The pharmacopoeias are underutilized, with thousands of medicinal plants remaining uninvestigated, and despite their potential. There is therefore an urgent need for integration. We need to embrace traditional medicine, and that can bridge healthcare gaps and advance equitable, culturally relevant healthcare. So we need to honor indigenous wisdom. Very important we do. We ignore it at our own peril. So I will, emphasize this with this quote, which says, every medicine was once a folk remedy. The science we value today began in the wisdom we dismissed yesterday. What about the colonial period? There was disruption of traditional medicine, and this was systematic. The colonial powers of the day, they criminalized traditional medicine, dismissing it as unscientific. Western biomedicine displaced community-based care and excluded indigenous knowledge. Sacred sites were destroyed, oral traditions were broken, and as a result, vital healing knowledge was lost. Now, biases still persist. Medical training still overlooks African remedies, and stigma against traditional healers continues. So why did it colonize public health? We need to do that. Decolonization basically means reclaiming health sovereignty. Decolonization will restore indigenous practices, empower communities, and enable self-defined priorities and solutions. Decolonization will also, the colonial legacies have created inequities in healthcare access, research, and policy. Decolonization can correct that. This decolonization will address these systemic imbalances. Now, health interventions rooted in local beliefs and practices are more accepted, so we need to decolonize. Traditional medicine, long suppressed, offer effective, culturally sensitive healthcare, and integrating traditional and modern medicine systems will create a more diverse, adaptive, and people-centered approach to public health. And again, let me reemphasize this with the quotation by Dr. Margaret Chan, former Director General of WHO, who said, "The two systems of traditional and modern medicine need not clash. Within the context of primary healthcare, they can blend together in beneficial harmony, using the best features of each system and compensating for each weakness, for certain weaknesses in each." That underscores the need for integration. So when we propose decolonization, we are not saying one should take over from the other, but just to ensure that they coexist to the benefit of our people. Beyond political freedom, that's what public health means. It's about recognizing and integrating traditional healing practices and worldviews into health systems. It's about designing health interventions that reflect local cultures, histories, and lived realities. It's about challenging colonial hierarchies in health policy, research, and decision-making. It's also about addressing structural inequalities, which are rooted in colonial legacies and affect health access and outcomes. And finally, it's about involving communities as co-creators of health solutions, not passive recipients. African traditional medicine remains resilient, it is relevant still, and it's recognized. This is because approximately 80% of Africans, this is a conservative estimate, rely on traditional medicine for primary care, both rural and urban. About 25% of currently commercialized medicines are from plants, with a significant portion, even those synthetic ones, obtained from natural precursors. Practitioners offer accessible personal care where biomedical services are limited. So African traditional medicine still resilient, still relevant, still recognized. It's formally recognized and increasingly partnered with modern healthcare in countries such as Ghana. And in fact, in Ghana, there are health units within recognized hospitals, regional hospitals, where there are units specifically for herbal medicine treatment. Ghana, Nigeria, and Cote d'Ivoire have developed national pharmacopoeias to document and standardize their traditional remedies. In this case, specifically the plants. And Ghana stands out with several innovations of traditional medicine development. So some of them, in 2000, Ghana established the Traditional Medicine Practice Council as a step towards formal regulation. Pentecost University, a Christian university in Accra, where I'm the pro-vice chancellor, has introduced a course called the Doctor of Herbal Medicine. This is a 6-year program which trains students to become doctors, authorities in herbal medicine. It's a pioneering program advancing research, training, and professionalization of herbal medicine. As far as we are aware, it's the first of its kind anywhere. And the Center for Plant Medicine Research in the mountains of Ghana has also been in existence for about 30, 40 years, or about 50 years actually, engaged in research into plants and also having a clinical outlet for treating patients with medicinal plants. Nigeria's National Institute for Pharmaceutical Research and Development, and NAFDAC, are also leading the development, regulation, and commercialization of herbal medicines. And I understand the Igbo traditional and herbal medicine is also making groundbreaking contributions. In South Africa, a lot of research has been going on into plant medicines. East Africa, in fact, the journal of which I'm the editor-in-chief, you get lots and lots of publications coming from Ethiopia, Sudan, and other places on the use of medicinal plants. Now, there has also been international support and collaboration. WHO has been very active, so has the African Union. And of course, the West African Health Organization, ECOWAS, also endorsed traditional medicine integration and regulation. WHO's Global Strategy on Traditional Medicine 2014-2023, which is about to be renewed, aims to support the integration of traditional medicine globally. And then African Union's policy frameworks also advocate for it. WAHO has had a program for traditional medicine. In fact, it's the only structured program on traditional medicine, again, anywhere. And it's been going on for the last 20 years or so. And I happen to be the pioneer program officer. Now, a few years ago, WHO conducted a survey to have a snapshot of how far traditional medicine has developed in the countries. So they did one in 2005 and decided to repeat it in 2018 to see where countries are. And it turned out that member states of WHO, which is, I think there are about 52 of them, in 2005, for example, only 12 had a national policy on traditional and complementary medicine. By 2018, and I'm sure this has gone up by now, 40 had national policies. Now, if you look at even research, national research institutes, there were about 18. Now, as of 2018, that has almost doubled. Regulation of herbal medicine remains very contentious in many countries. The regulation is not as effective as it should be. But then there are quite a number of countries now which are regulating in an effective way. And of course, we have registration of herbal medicines from 8 to 23 in 2018. So challenges exist. And some of these are stigma and skepticism. That remains the biggest problem. TM is still seen as unscientific, even within health systems and communities. There is lack of regulation in many countries. In others, the regulation is very poor. Non-standardized practices and minimal formal training lead to inconsistent. This is what our program at Pentecost University seeks to address. Underfunded research, limited support for clinical trials, lab access. It is very difficult to get funding to undertake herbal medicine research or traditional medicine for that matter. And then policy and institutional barriers also exist. Traditional medicine is excluded from formal healthcare systems and policy spaces in many countries. And of course, there is poor collaboration between traditional and biomedical practitioners, often operating in isolation. And as a result, this is hampering effective integration in many countries. Now, traditional medicine or herbal medicine is widely used, as I've said. So this is one reason why we need to integrate. We need to integrate because it's well patronized. We need to integrate because there are proven therapies that are shown from the anti-malarials. And of course, there are also medicines which are used to treat cardiac problems, which are plant-based. The list is endless. It's also holistic and it's culturally relevant care. African traditional medicine promotes balance. So that is holistic, balance, body, mind, and spirit treatment, not just. And the point I'm stressing here is encapsulated in this cartoon by WHO, which talks about what integration can actually do. And it says that if modern medicine and traditional and complementary medicine are able to collaborate and get that traditional medicine integrated, the patients and the public will actually be the beneficiaries. Again, traditional medicine is cost-effective and community-based. Collaboration will enrich drug development. In fact, several plant extras have provided leads for the production of life-saving drugs. And I hope this will continue into the future. So now, what public health professionals and the promotion of African traditional medicine. What can public health professionals do to help? You could help by advocating for integration, push for ATM inclusion in national health systems, and support dialogue between traditional and modern practitioners, promote evidence-based research, lead clinical trials, and document the best practices in African traditional medicine and its impact on public health. And you can also support by educating and raising awareness. You run campaigns on safe use of traditional medicine, train practitioners on cross-disciplinary care. Again, you can also help by supporting integrated policies, help develop inclusive policies and regulatory frameworks to ensure quality and safety. Then also help build partnerships and funding, connect governments, NGOs, and researchers, advocate for funding to support ATM. So the call to action then, what can we do to decolonize traditional medicine? We need to support legal recognition and protection of rational traditional medicine practices. We need to treat indigenous knowledge as essential, not secondary to healthcare systems. We need to invest in research, documentation, and education to validate traditional medicines, and we need to train the practitioners also. We need to promote professionalization through accredited training programs like what Ghana is doing, in particular, the model adopted by Pentecost University, and also ethical standards that elevate its role in the health workforce. It is pointless promoting it if people cannot apply simple ethical principles. You cannot have a situation where people are advertising all sorts of things to denigrate the profession. We need to promote cross-sector collaboration among governments, NGOs, researchers, and communities to create inclusive, culturally grounded health systems. And we need to strengthen public awareness and education efforts, which will honor local healing traditions while promoting safe, and that is important, promoting safe, evidence-based integration with modern medicine. So the time to act is actually now. I need to end by reminding us of this quote by Arthur Schopenhauer, who said, all truth passes through 3 stages. First, it is ridiculed. Second, it's violently opposed. Then third, it is accepted as self-evident. This quote clearly shows the journey of African traditional medicine from marginalization to recognition. Thank you very much for listening. Je vous remercie. Obrigado.
Promotion of traditional African medicine, alternative and herbal medicine, the way of decolonizing. And I go through these definitions next slide. We know, I greet everybody, AFPA and the West African, all health sectors, dignitaries, all health practitioners, all invited speakers, guests, indigenous, and social media. Now, traditional medicine, we know, is a comprehensive field that refers to several traditional medical systems. And the indigenous medical practices is so termed taken as where the Western medicine is dominant and has not been really incorporated into the national healthcare system. That's where you term it complementary, alternative, and so on. But we all know that traditional medicine is practiced worldwide in different degrees. And traditional medicine practitioners are known to be, practices are known to be explicable or not. And it's passed so many generations orally, either by practice, few written, but we know that they are infected in their specialties. And most products are from natural resources. The present state in Nigeria that I know, traditional medicine practice has existed since man's existence. It's indigenous and has come to stay as the preferable first line of management of diverse health care problems. There's this universal newfound respect for the inherent national healing properties. And we see that growing greatly. It's quite effective. It's growing more relevance, more knowledgeable significance, more understanding with scientific researches on medicinal plants are all on the increase. But it is yet to attain its full potentials, more so if our continent governments embrace traditional medicine development, allow and include the practices into our national healthcare systems. I think that is where the major problem is, at least in Nigeria. It should run parallel alongside with the colonial practices. It's sure to gain more acceptance and preference once this is greatly understood and incorporated into our system. Health is wealth, we all know, it's a common saying. And we are created wealthy, very wealthy. Africa is wealthy. But we need to utilize our wealth to gain sound health for each and every person, indigenous and those in the global system. A healthy nation is rich and quite progressive. Our main goals are to restore, sustain good health care system in all our African countries as divinely ordained. Divinely ordained because we have the vast, uncountable natural resources that we can turn into products that will be useful for the whole world. Targets to sensitively consider our population is the population's well-being and posterities. We can last until eternity. As previously said by the first speaker, 80% of our people still consult our traditional medicine practitioners. So we need to open all avenues that will make traditional medicine practices evidence-based for effectiveness and accuracy, and to run parallel with the present national healthcare system. This we must approach vigorously and address and achieve. Our roles continue. The terms traditional, complementary, alternative are all medical care systems for delivering and achieving the best wellness to our peoples and the entire world's peoples. They are all members of the same body, indigenous. They are all systems that traditional, complementary, alternative medicine practitioners obtain, and they practice from training inherent through indigenous generations, some documented, and majority just passed down orally. They are communicated orally. TCAM also has every health discipline as existed in the conventional method of the national healthcare systems. The roles played by the Orthodox practitioners, this is one of the goals by decolonizing. We'll be able to guarantee that TCAM practitioners will be capable enough to manage patients effectively. But having boards for regulations in each state of each nation. Regulation is very important, and Lagos State started this very well. The Lagos State Traditional Medicine Board have lasted for the past 44 years, but it seems to be stagnant because the government is not actually integrating the practice into the national system. This present governor, Governor Sanwo-Olu, did so when, from year 2020 to 2023, when I was there. He tried his best, but we're still so much hampered. One thing is to say you want to do something, another thing is to begin to implement what we have said. The implementation is somehow hindered. We're not doing as well as Ghana is doing when it comes to, this integration. And it's so very important. Without integrating, it will just remain stagnant and will be punishing our population, which is very unfair because we are so endowed. We are so endowed. And, the TCAM has every health discipline, like I said. So, and now allowing these disciplines to work will give us even better health results, healthier nation, healthier people, and of course, where you have health, you see that economy goes very high. It's very progressive, and everybody is very well catered. So the role played by the Orthodox, we must emphasize and encourage the government to make more policies that will actually involve the traditional medicine practitioners to be seen alongside the Orthodox practitioners. That still has to be achieved in Nigeria. As said earlier, we are endowed with abounding nature's blessings. And TCAM practitioners are also, right now, with the global downturn of the economy and our people moving from the country outside, that you call the Japa syndrome, for greener pastures, we see that the number of health professionals in Nigeria has dwindled tremendously. Right now, we have at least 9,000 registered traditional medicine practitioners, as compared to less than 3,000 now in Lagos State. So you have more of these traditional medicine practitioners doing their best to maintain the health needs of our people. So TCAMs are well trained, the practitioners, and they are available. They are already providing cost-effective and the cost-effective treatment and management of our people's healthcare problems. Our practitioners and Orthodox have the ability to cooperate, meet the healthcare needs of our people, set up edifices where people are given and allowed to choose their system of preference, which is not going on right now. This is what we must encourage so that people are given the choice. Already 80% of them are being sent back. But when the government now gets really involved, enthusiasm to practice also is heightened where the traditional medicine practitioners are concerned. And I'm sure they'll be out to want to prove their best. There's boundless, we have researches have been done, countless, and concluded as effective on our medicinal plants. In our tertiary institutions, they should be collated and for clinical trials, and not just to attain promotions to professorial grades. That's what is happening. They should, we should encourage the collation of all these researches that have been concluded and proven effective into drug production, from plants to productions. Reference system, where and when necessary, must be encouraged and freely practiced without hindrances. The Lagos State Traditional Medicine Board was able to achieve that. In the last 10 years, they have the referral system that's, more so for the traditional birth attendants and community birth attendants, practitioners, that should they run into trouble because they are not allowed to give blood transfusion, they're not allowed to set up drips, to give IV management to people. So they've been given that privilege to quickly refer patients to the orthodox practitioners so that can save more lives and also maintain good health in collaboration. This affords best care and also creates job opportunities for our people because more people will be engaged in this system. And we can have vibrant economic growth through standardized, quality, international exportation. We are able. We have challenges. True enough, the colonial demeaning mentalities continue to be a stumbling problem. And it's the cause of retrogression. The retrogression we have today is not because culturally we are inferior. It is because colonization has come, it's taken their language. Once your language is taken away from you, you are reduced to next to nothing. And this has affected, I'm sure, Nigeria as well as all the other African countries. The problems they have are our own, and our suffering are from our own inferiority complexes running inside us. We need to dispel this and get rid of this. We are much more superior than how we see ourselves. I'm sorry for that interruption. We are more superior than we see ourselves. The stigma is that they call the indigenous healthcare from our people fetish or cultic, lacking dosages. They must be avoided, and they need to nullify. We need to nullify these notions. Our forefathers had dosage. Yes, the modern way of producing products were not the same as they were producing. But then, when the colonial masters came, they met life and they met abundance and prosperity. All we all need to do is to use some of the orthodox ways of producing products, from plant to products, and at the same time, to hold on. We need to do a lot concerning our people. The few that have no affiliation for the traditional way of treating our patients. Most of the orthodox trained, of which I am one of them, most of them still believe strongly, oh, don't get close to them. They are dangerous. This is not true, and it's not so. This is, a challenge we need to get over. Maybe through the media and
yeah, Professor Ostello, you have 2 minutes.
Clinics.
Yeah, 2 minutes. Yeah.
Okay.
Okay.
Thank you.
Conclude in 2 minutes.
I'm almost concluding anyway.
Okay.
Yes. So the challenges we have are within us, which we can correct, but we need more collaboration. Like I said, a lot has been achieved, and we need to bring them together, get them into clinical trials, and standardize them. In conclusion, I would say that togetherness and unity of purpose, we shall promote, get progress and uplift our status.
Make it up,
attitudes change, reclaim. May our struggles yield greater results than our envisaged in consignment. Please, these slides are available to other people. You can go through them and, get into contact with me too. We need to move forward. We are ready to cooperate with each other. With more hands on the deck, our people and our government leaders together, we can make undeniable thunderous breakthroughs and regain our stolen and lost status. Thank you for listening.
Thanks to everyone. I'll be talking about decolonizing public health in Africa and the tropical countries, effective harnessing of solar energy in Africa and the tropics. It's a webinar by African Federation of Public Associations as part of the Global Public Health Week of the World Federation of Public Health Associations. Well, I am a medical doctor. I'm a consultant public health physician, a health system development expert. I'm the project manager for RES for Healthcare. Recently, I was elected the president of the Association of Public Health Physicians. So let's look at the terms itself. What is decolonizing? It refers to the process of dismantling colonial structures, ideologies, and dependencies that continue to shape our society, institutions, and knowledge systems. It involves reclaiming our autonomy, promoting indigenous knowledge, and building self-sufficient systems that are tailored to local contexts rather than impose external models. So this definition talks about us claiming our autonomy, which is important because without any form of autonomy, we cannot talk about decolonizing. Now, how do we now decolonize public health? Public health decolonization means shifting from the healthcare systems influenced by colonial legacies, such as dependency on Western medical models. We just talk about the African traditional medicine, imported technologies, and urban-centric models toward a locally driven, equitable, and sustainable health system that achieve common good for all. The building of disease palaces in urban settings have not helped us in terms of public health. It has helped us address illness or sickness, but health and disease are not the same. So public health centered on colonial master ideologies will not address some of the things we need to address. This includes integrating indigenous healing practices, as just been demonstrated in the last presentations, strengthening local health structure, and ensuring that policies reflect the unique needs of communities they serve. It requires innovations that break away from these constraints and building self-sufficient and context-specific solutions. Context-specific solutions. These solutions must be context-specific. It's important to understand this. Now, if we practice primary health care by its strict definition, we achieve decolonization without any other discussions. Now, let's look at this definition. Primary health care is essential health care based on practical, scientifically sound, and socially acceptable methods and technologies made universally accessible to individuals and families in the community through their full participation and at the cost that the community and country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. It forms an integral part of the country's health system, of which it is the central function and main focus on overall social and economic development of the community, which means that if we are looking at context-specific situations, integrating traditional medicine will be naturally done. If we are implementing primary care, it means we work at that level where people work and live. It is the first level of contact of individuals, the family and communities with the national health system, bringing healthcare as close as possible to where people live and work, and consider the first element of continued health care process. So it's important to understand this definition. And if you ask me, we don't need to talk too much about these issues if we have created a system to implement primary care the way it was defined in 1978. But it appears that most investment is not done there. But it's important to also understand that the sun shines where people live and work. So if the sun shines where people live and work, it means that we have capacity to take advantage of the sun. So let's look at the sun in Africa. That map that is there shows the sun in Africa. Africa is even considered and referred to as the sun continent, or the continent where the sunshine is the greatest. According to the World Sunshine Map, you can see there, Africa receives many more hours of bright sunshine during the course of the year than any other continent of the earth. Many of the sunshine countries on the planet are within Africa. But the unfortunate situation is that there is lack of investment to maximize the sunshine that is available to us. I can tell you that even vitamin D deficiencies people are experiencing in urban settings because they live in rooms from one house to the office and they don't get exposure to sunshine. But we have it for free. Now we can generate energy with it. Now, what is sunshine distribution across countries in Africa? Most regions in Africa experience 280 to 260 days of sunshine per year. The sub-Saharan and Sahel regions receive more of the sunshines, and they have about 3,600 hours of sunshine annually, which means 99% of the year they are experiencing the sun. Even the tropical and equatorial regions have up to 350 hours. Egypt, through Sudan, through other countries, and Nigeria experience 3,000 hours of sunshine yearly. But of course, Africa gets more of this sunshine, and we don't use it per square meter more than any other part of the world. So what are the raw materials that we need to utilize the sunshine? We're talking about alternative energy. We're talking about solar energy. But let's focus on solar energy. What are the raw materials that are available in Africa that we can decide today that the sunshine is available to us, we can use it? First is lithium iron phosphate. Now, most batteries, what we call the raw material for battery energy storage systems, most batteries are using the lithium iron phosphate technology and the nickel manganese cobalt batteries. They are the most dominant because according to International Energy Agency, this system will continue, and of course, with the new demand, we know that it will continue. The demand for critical material like lithium, cobalt, and rare earth elements could nearly triple by 2030. In fact, by 2050, this would have been 500% times increase, depending on the climate policies and technologies advancement. Now, China currently dominates the processing of this crucial battery materials. So we talk about them being available. We're not processing it. We're not using it. The same way that happens with fuel. Fuel is exported in crude form, is processed and brought back to us. The same thing is happening with these raw materials. Africa is home to substantial share of the world clinical minerals. Look at DR's Congo, for instance. 70% of cobalt production in the whole world is from DR's Congo. South Africa controls 78% of the global reserves and production of manganese. Zimbabwe holds the largest reserve of lithium ion worldwide. Zambia is now the world's 7th largest producer of copper. These are materials that are used for battery production. Morocco is crucial to lithium ion battery production because of their phosphate production. About 70% of the global supply of phosphate is coming from Morocco. And of course, they are using this because they have integrated battery mineral value chain systems. Most countries don't process this and will still carry these raw materials and export it to China and other locations. Now, what are the raw materials required for panels? We'll talk about batteries. What are the raw materials required for panels? The crystalline silicon technology consumes most of the 95% of solar photovoltaic production. Silicon is the main raw material for photovoltaic solar panels. Others are silver, copper, tin, and aluminum. Now, in Nigeria, we should talk about the tin city. When we talk about mining of tin in Jos, I don't think those minings is still going on. Silica reserves, essential for solar panels glass manufacturing, is found in Egypt, South Africa, and Nigeria. Again, more raw materials are exported. Copper, cobalt, and manganese are critical for solar component wiring and reserves in Zambia, DRC, and Gabon. And of course, aluminum is part of this. So it's important to understand that we have all that we need to produce energy from solar. All. Now, let's now relate it to the health system. Unfortunately, despite this, it is estimated that 1 billion people around the world are served by healthcare facilities without reliable electricity or with no electricity at all. Of course, the situation is worse in Africa. In sub-Saharan Africa, only 40% of facilities have reliable electricity. We know that reliable electricity is essential to save lives and crucial for medical equipment, childbirth, immunization, routine and emergency care. Now, with all this, with all the raw materials, this is happening to us. Reliable energy provision, particularly electricity, is a major enabler of universal health coverage. We cannot be talking about universal health coverage when the hospitals are in darkness. And we have what it takes. We have the sun, we have the raw materials for battery, we have the raw materials for panels. Of course, this document can also give a light to what I'm talking about. Maybe you download and read Energizing Health, Accelerating Electricity Access in healthcare facilities. So what are the systems? How does solar energy strengthen public health? First, it guarantees reliable power supply to facilities. So you don't need any other form of intervention. We don't need poles to bring light from anywhere. We don't need approvals of any kind. In fact, based on the regulation now, except you are doing mini grid of a large level, anybody can provide solar anywhere. Solar power solution can ensure uninterrupted operations, reducing mortality and improving healthcare systems and outcomes. It's cost effective, cost and sustainable is there. Once you look at it from the long-term perspective, it is cost-effective alternative that reduces operational costs for healthcare facilities, freeing resources for medicine and personnel, and of course, patient care. It improves access to healthcare. Off-grid solar solution can enable mobile health units and telemedicine in remote areas. Once the light is guaranteed, you can mount your devices. We provide this internet. You can have convenient access to the facility that put up telemedicine models. Of course, environmental health and health benefits are things that we know. Solar solution cut down air pollution, lowering the incidence of respiratory tract infections and other conditions. Now, what are the strategies for effective implementation? First, government across board must invest in local manufacturing and maintenance because we have the raw material, so there's no need talking about importation. Local production of panels is possible, inverters and batteries can be done at low cost, and then, of course, create jobs. By so doing, we are investing in the sector. One critical point that needs to also be done is training technicians in installation and maintenance to ensure long-term sustainability. Most of the people who are doing maintenance of any device now, they were trained to maintain generators. Most electricians don't know anything about solar. All we need to do is convert this critical mass of people, train them on solar, and engage them. Private health self-participation. We need to have regional mega factories where there is public-private partnership and investment. We need to talk about research and development. We need policies that encourage solar adoption through tax incentives, subsidies, and regular support. Of course, community engagement. If we're implementing this without community engagement and ownership, most people will not even learn. But once solar becomes part of the community, they will learn the process and grow with this as a source of energy. What are the major challenges that we must overcome? First, the continent energy infrastructure must be improved because mining and mineral processing are energy intensive. This is one area that African Development Bank and other banks must invest into. Political instability and infrastructure deficit. We are still talking about wars in DRC Congo, other countries having issues around criminality and stuff. We cannot achieve results. We will have political instability and fights all over the place. Limited access to financing, with the borrowing costs and other things very high. Of course, regulatory uncertainties and bureaucratic bottlenecks and skill level that is lacking. There must be intentional technology transfer to ensure the continent progress rapidly. So what are our current efforts? What have we done in terms of trying to see that within what we have in our hands? Now, he said that you don't need to go and look for something else, use what you have in your hands and do something. So we created these principles, guiding principle of 7 + 3 = 10. What is 7? SDG number 7 is about affordable and clean energy. Number 3 is about good health and well-being. So when you combine these two, you get 10. So 10 is now reducing inequality within among countries and, of course, within the country. The fact of putting solar in a primary health care facility in a rural community gives them advantage and reduce inequality. They can do they can keep blood, they can keep drugs, they can keep vaccines. And that is the same way that happens in the urban setting. That way we're decolonizing because we're not talking about urban-centric activities that deprive the rural communities. In the last 3 or 4 years, we've done this work focusing in North Central Nigeria, basically for 2 reasons. One, the sunshine is more than 5 hours per day across the year. Of course, it's within the geographical location where we can shorten distance of travel. So Having Essence have done this. We have done stakeholders engagement. We're engaged with hospitals. We've engaged with state government. We are currently implementing the health facility electrification project using a standalone solar solution for 5 countries, for 5 states in northern and central Nigeria. Now we know this for sure, that the cost of other energy sources, be it fossil fuel and main grid, is increasing. In Nigeria, it has practically doubled. As patients are dying, hospitals are equally dying because they cannot make money and they shut down. Private hospitals are finding it difficult and extremely difficult to provide quality service and still break even. So our system is simple. We look at it. The race for healthcare concept is how can we harness the sun rays that hit the roof of the hospitals and convert them to productive use in the hospital. So we have a system, hybrid inverters, lithium-ion batteries, and of course, efficient panels. But importantly, we have a monitoring device that monitors all the installations across the country. So it is important to understand this project have a target 1,000 connections in 3 years, and of course, practically we're working across 5 states and then extending to other parts of Nigeria. We've also done partnership by building partnership across the globe, looking at options that can help us in terms of specializing. Now, it's important to understand that awareness creation, the healthcare system as it is, need to have that nexus where people know what to do. We have people who are in the leadership, they don't understand the benefit of what we are talking about. So in the last few years, we attend events, we have event-based promotional activities where we educate people, engage them, and teach so that people can understand the benefit of what we're doing. Now, what are the key challenges? There are 5 challenges generally around putting solar and ensuring that this decolonizing work will do. First challenge is the erratic power supply, but importantly, expensive upfront payments that are as a result of importations that are unstable. So currency is unstable because we're not producing these things is difficult. But we run what we call a lease-to-own model with affordable financing model and revolving of funds among private hospitals. So private hospitals will have designated amount of money that goes there from any angel investors, and this money keep revolving. We also talk about training at all time, building capacity, and ensuring that what we provide is quality. So we'll get direct equipment from manufacturers, and they move from factory to product to the locations. So building a network between health and energy sector is critical, and we must understand it. But at the emphasis on that is financing. Financing is critical. Technical know-how and skills minus finance equals to frustration. But when you add finance to it, it becomes exciting. It's on that note that Access Bank developed this product. Working with Access Bank, we now have the Access Bank Solar for Health product that Access Bank is now promoting. They can give up to 200 million naira for any hospital that meet the requirement, and they simply pay on the lease-to-own model over a period of 48 months. That way we are sorting that down. Then what do we use 48 months? We will explain. Now we have looked at the system such that whatever you invest in solar, by the fourth year, you've totally recovered your money.
You have
now,
2 minutes.
Battery system.
2 minutes, Doctor.
Okay, fine. When you say battery system, where will do that? The understanding of system will know that solar goes down while others keep going up. Now, these are pictures of some of the work we do. We have angel investors, future enterprise model, and of course, cost recovery model that happens with it. My slides have ceased. Okay, so of course, these are pictures just showing us what we do and the things we do. We've done most of this, looking at options. Of course, it's exciting because we'll be honored in the course of the work we are doing. So what do we do? This last slide presents what APHPN under my leadership has committed to do. We are going to adopt 222 PACs across the country, see how we can raise money through crowdfunding or grant to make sure that these hospitals have at least solar solutions that they can now talk about. These are innovation for common good. The communities benefit, the health workers find the environment better, the health system improve, public physicians are excited, and of course, government funds what we're doing as a contribution to the health sector. What is the take-home message as a roundup? Africa has all the natural raw materials for renewable energy generation. So there's no excuse here. There's no excuse. If we want to decolonize, there's no excuse because God has blessed us with the sun and blessed us with raw materials. We must establish gigafactories, which are large-scale manufacturing factories dedicated to producing lithium batteries as a game changer. Effective harnessing of solar energy presents a unique opportunity to build resilient health systems, improve accessibility, and reduce environmental and economic burden. Decolonizing public health in Africa and the tropics require a paradigm shift. And this paradigm shift will have all the tools that is needed for it to happen. In conclusion, by investing in localized energy solutions, Africa and other tropical nations can pave the way for equitable, healthier future, free from the constraint of post-colonial dependency. Public health association in Africa must take responsibility to hold government accountable, but importantly, provide purposeful leadership to institutionalize these things we are talking about. These innovations will make a change. And of course, we'll not be talking about urban-centric healthcare. We'll be talking about healthcare that is across board, that is beneficial for people who are in urban setting and also people in rural setting. Of course, we can create hybrid communities where those in diaspora can equally invest into this system by providing resources for this to happen through crowdfunding. And of course, we achieve what we want to achieve, the true primary care system where people get services they need at the time they need it and of where they work in the spirit of self-reliance. On this note, I want to thank you very much. But the idea is simple. It is for us and by us. That is me in that picture while one of the installations was done. And of course, for information more on this, the slides are with the organizers and our contacts are here. Thank you very much for your time. I look forward to engaging with us to see how we can provide technical support to some of these things happen. Thank you very much.
Great. Okay, so I am Victor Kulu. I'm the medical sociologist at the University of Medical Sciences, Ondo, Nigeria. So I just want to commend the good work of the presenters and to also note that I'm thrilled, very, very thrilled that clinicians, public health physicians, scholars, and practitioners are beginning to think about pushing the agenda for the decolonization of healthcare. Now, I just want to suggest and propose that it will also be good to start thinking about decolonizing, medical education itself, which should actually be a means to an end. So I personally have research interest in the area of traditional medicine, where I actually did my doctoral research, and I've worked for some time. So, but I think that decolonization is more about the mindset. While I agree with what the presenters have said, I think it's more about the mindset and the crop of physicians, whether at the level of practice or scholarship that are being churned out. There's the need to orientate them to start seeing, appreciating, and utilizing the value in indigenous resources. Because over the course of my scholarship, I noticed a kind of hostility, towards indigenous healthcare practice, indigenous resources, and all of that. I think we shouldn't throw away the baby with the water. A lot of adverse outcomes have been associated with it, but I think that there are still value, especially in a resource-constrained setting such as we are in. So this is my submission. Thank you very much.
I'm Dr. Lindo from London. I'm from the diaspora, St. Lucia, namely. I am so excited to see what has been said, today. But I believe that the most important change has to be the politicians. 2 years ago, I was in the Congo, Tanzania, and Zanzibar, and I noticed that the doctors were under great coercion by the government. And who was leading the government? Big Pharma. So there was a Right Honorable Mr. Brigham spoke 2 years ago in our parliament in London, and he said that Big Pharma has such a control over the NHS that we need to curb their power. And that is the problem I'm feeling, that some doctors want to verge out and do alternative medicine, but they are coerced by the powers that be. They don't want to lose their license. So something needs to be done with the politicians so that they can open the way for integrated medicine. It's so wonderful to hear the presentation so far. I am so excited. And I'm thanking God that at last we're breaking the chains and becoming free. Thank you so much. God bless.
Well, first I must commend the African Federation of Public Health Associations for putting up this webinar, which is quite informative and timely also. Then I congratulate the speakers for excellent job done, each of you. Next, I must humbly and respectfully disclose that I was the coordinator for the National Traditional Medicine Development Program for Nigeria from around 1999, 2008, and the pioneering work that was done throughout that period. The records are there for Nigeria. At that time, Nigeria and Ghana were at par, and with all humility, I might even say we were leading. But afterwards, Ghana has gone far ahead. Nigeria has been kind of static in terms of progression in the area of development of traditional medicine. The most significant step forward that Nigeria has taken since that time was the establishment of a full department of traditional medicine, traditional, conventional, and alternative medicine in the Federal Ministry of Health. That's now a full department. Okay, and even now, I'm privileged to be the chairman of the National Committee that revised the National Policy on Traditional Medicine for Nigeria. The maiden policy was developed in 2007. And at that time, President Obasanjo insisted that even that policy must be brought to the National Executive Council. He personally chaired the meeting on that day to review it, to establish the maiden policy for Nigeria. And then we revised it just last year. But let me say the most important thing within the time that I have to speak is that unlike in Ghana, where Professor Busia said that they now have units that are practicing traditional medicine in the health facilities. That is not available yet in Nigeria because the law that's meant to regulate that, make that happen, has not yet been passed. The bill for, and listen carefully to this, the bill for the establishment of a traditional medicine council, regulatory council for Nigeria, in the National Assembly of Nigeria since 2007. That bill has been there in the National Assembly since 2007. From one session of National Assembly to the other, they have refused to pass that bill. All right, that is the reason why you cannot have people practicing traditional medicine in the health facilities of Nigeria. If a doctor, an Orthodox doctor, practices traditional medicine in the hospital in Nigeria, it is illegal. And the patient can take you to court because you are practicing without legal backing. Okay, so that's the main difference, that is issue that is handicapping further development of traditional medicine in Nigeria. I've had the privilege of meeting Professor Busia before, while we were with WAHO, and I was national coordinator for traditional medicine in Nigeria. I was also quite familiar with the predecessor of Professor Oshitelu, Dr. Bumio Mose-Indemi, who was the coordinator of your traditional medicine council in Lagos State. But let me say, with all due respect, you are complaining about some handicap with development of traditional medicine in Lagos State. Let me say to you that Lagos State is the leading state in development of traditional medicine in Nigeria and has been so for ages. In fact, in developing the policy for traditional medicine in Nigeria.
What has come up from the discussion we have had so far and the presentations is that we need to develop in our countries a similar program that Ghana has developed, Doctor of Traditional Medicine. And in the process of that, to develop the ethics and regulatory guidelines for doing them.
I speak on behalf of, I represent the African continent at the World Federation of Public Health Associations. So as on the governing council, so I'm very glad that it has been possible for us to have this webinar from the African Federation of Public Health Associations. So that's the first bit. The second bit is now commenting on the presentations. I would like to say that as Africans, we need to do a few things from what has been discussed. How can we, as African states, work together for a common goal? My view would be, could we develop cross-country research, development, innovation, and scaling? Because Dr. Tolu has just said that a lot has been done in researching, but then sometimes we don't scale it up. Could we, through the various organs which are available to us, WHO, AU, and so on, work out a continental research, development, innovation, and scaling program so that we are able to harness what has been done in different countries and we can use it as a continent as part of the decolonization process?
I think there are calls for action, like focusing, targeting research on traditional medicine, and the Ghanaian experience really I appreciate. I support my colleague who spoke just for me. Having doctor of phytotherapy is very, very critical because creating human resource makes a difference. Making a system, we need to have systems thinking. There are fragmented here and there, fragmented efforts. So there has to be a system thinking end to end from the traditional medicine up research, development, and then policy. I think that is what we are lacking as a region, and also I think the presentation, of Dr. Basia, I said, African traditional medicine incorporates body, mind, and spirit or environment. I think I just wanted to ask, him, does it mean that traditional medicine, does it include all the spiritual therapies also? There are therapies and spiritual therapies, like, using different spiritual therapy, holy water and others, does that mean? Maybe that is a question I have. But in any case, system thinking should be the mainstay of decolonizing vehicles. Thank you very much.
The process of decolonization must start from us, from each country, because I remember we can start our decolonization process through utilization of the research done by the WAHU when Professor Busia was the director. We have been able to identify 6 priority diseases, and we need to make sure we push this one to the policymakers so that we stop importing all those unnecessary drugs from the Western world. And I thank God for what Trump has done by removing the AIDS from Africa. I think we have to look inward now and find solution to our own problem. Our problems lies with us, within ourselves. We need to have a conference of conventional practitioners, medicine practitioners, and also traditional medicine practitioners, as has been done in WAHU. We need to have this one, continue this one, because without that, we will not be able to stand up against the big pharma. We need to reorientate my colleagues in the orthodox medicine, the need for us to think African first, instead of trying to promote the products from the Western world. And also concerning the law, Nigerian government has passed a National Health Act bill, and it has become a law since 2014. But nobody has the political will to push this one through. It is there on the shelf. And also the Ministry of Health, we need to look inward at what is happening in our Ministry of Health, because I was instrumental to the establishment of Directorate of Traditional and African Medicine in that department. And I know what we have been able to do in Lagos since 2006 by talking to the legislator in Lagos State so that they pass the health sector reform 2006. We need to do this also in other African nations. Without that, we just continue parabolating, and Africa will be seen as a country where waste products or Western waste products, they can just be pouring it to us. And when we don't stand up, because I've seen what is going on TB, I've seen what is going on Bill and Melinda Gates Foundation. But because of now, the position I am and what I'm doing currently, I just have to keep on watching, because I believe we have been able to do our own. Political will is very, very important. And also, we always talk about African traditional medicine, looking at the herbal products aspect. We need to develop human resource for health in African traditional medicine. Considering the current movement of our professionals to the Western world, we don't have enough orthopedic surgeons. We have bone setters. Our children are dying, mothers are dying. We have traditional birth attendants that we need to empower. All they are just bringing is kit for midwives and so on. Are we empowering these people? The only way we can do it, and the only way we can decolonize ourselves, is to look at this issue critically and think as African. We can think locally, act locally, and make sure we solve the problem of our people. Thank you so much.